Well, good morning, everyone. Is this a bit loud, or is it okay? Seems a little loud. Anyway, I am thrilled to be invited here this morning. My friend Karrie, we flew in last night. I had never been in Connecticut before, so this is a whole experience for me. So thank you so much for the invitation. A tiny bit about me, but I have a background in perioperative nursing for probably over 20 years. And I'm now working in academia, and I help Karrie in the clinical arena, but you can say a little word about yourself, Karrie.
Yeah, so been a nurse for decades and in the OR for probably close to 2. Have a real interest in research, actually worked in clinical trials for a while, which is a different beast, but was a unit educator after being a circulator for years, and was really able to meet Imelda and kind of use her as a mentor. And so now we work on some projects together within Baptist. It's roughly a 500-bed hospital. We work on some projects together, but she's given me the confidence and someone to brainstorm with about developing projects. I'm only lucky enough to have her 1 day a week. But we can collaborate on things that I can take forward to make a difference for our patients.
Thank you. And I think I have given presentations before, and so I typically, one of my passions is patient safety in the OR, because I feel like there are the most vulnerable patients in healthcare. I don't know if I've ever seen that in writing, but I will always admit that. And when I first started in the OR over 20 years ago, I was with a preceptor. And I remember saying to my preceptor, I feel like this is the most dangerous place in the world with all of the risk. And she kind of laughed me off, said, oh, you're new at this, you'll get used to it. And I think what I concluded is I never want to get used to it. I still think it's the most dangerous place all these years later. And when we start to go, oh, it's fine, we do this all the time, I think that's where we can get into some setting the ground for maybe some adverse events. So one of the things that we're going to talk about today is sort of the art of communication. And I know there's been so much presented on communication, and you think we'd have it figured out by now. And I think some people do, and some people do a really nice job. But there's some really key elements I think that are worth revisiting and sort of re-exploring in ourselves, how we communicate with each other as part of a team.
We hold classes, and we're going to go in a little bit more, some of our projects that we've done where we wanted to actually collect data, but then I've been able to take that onto now all of our new hires into surgical services come to one of our classes. All of our preceptors, we're trying to get them to come to all of our classes, just to make safety something we really talk about and what our culture is. And what I think is always so interesting is whether you've been a nurse in the OR for 20 years or if you've been a nurse in the OR for 2 months, we always get feedback that nobody talks about this. The things that we talk about in our class, sure, you can find it in the journal if you subscribe and you're looking, it's there, but we don't bring it into our orientation or our onboarding.
So just some learning objectives here. We identified 5, just talking about effective communication, psychological safety, that's been around in the literature for at least over a decade at this point. Hierarchical gradients, I think this is something that we all know what it is, but I think that the term hierarchical gradient is interesting. And then how we can improve and managing just conflict in the workplace. So really the introduction, kind of getting back to what I said earlier, a culture of safety, I mean, it really is vital. And I think we like to say, sure, we have a culture of safety, but I kind of liken it to good, let's say, dental hygiene. So let's just say you go to a dentist and your dentist says, oh, let's clean your teeth are in good shape, you have no cavities. And it's not that we would say, okay, well, I'm good, so I don't need to floss and brush anymore tonight or tomorrow or for the next time. It's something we kind of have to keep talking about, because if we stop talking about it, that's kind of where then we will get the cavities. And so it's, again, something we just need to keep on talking about to keep the culture of safety up. The AHRQ, I really like this organization, Agency for Healthcare Research and Quality. They really, it's not unknown that there's actually, when there's poor team communication, it's one of the biggest downfalls to effective culture safety. We also want to talk about here speaking up. There's been a lot of articles written also about speaking up for safety. Are any of you familiar with the speaking up voices in the OR, in the AORN journal? Have you? Yeah, so that's the thing. I actually was invited to coordinate that column recently, and I found it really, really interesting. So for those of you who wouldn't know what that is, it's really kind of highlighting areas in the OR where someone has spoken up for safety and how that has unfolded. And some of the stories that I have read, some of them are really not pretty stories, and some of them then have good outcomes. But again, it's about highlighting how we really do need to keep our eyes and ears on what's going on in the OR and being able to speak up and feeling safe to speak up in the OR. I feel like the challenges are everywhere. And one of the things that Karrie and I have really said is when we come into the OR, and if you're a new person or you're coming in as an orientee, we're very good at skills checkoff, like how to insert a Foley catheter, a sterile technique, and positioning, and all of these things, of course, that we must have. But nobody does a competency on speaking up or communicating effectively or team dynamics. It seems like you think people would kind of get that, but a lot of people really don't. And I just wondered, are any of your hospitals actively doing something about teams or communication techniques in your hospitals already as part of orientations? Okay, excellent. Is somebody thinking that you probably should do that, but it's just kind of hard to get around to it? Yeah, and it is hard to get around to it. It involves kind of, you know, a lot of buy-in from leadership, your managers, getting the time, and so there's logistical challenges to it, but I think it is really, really important.
It is, and I think not only is it important, the topic is important, but it also, I think, like gives value and weight to your staff to know that, you know, you're not just here teaching me all those clinical skills, you're teaching me some of the communication, the interpersonal skills that I'm going to need. I feel equipped to go into the OR where there may be a perceived hierarchy, or, you know, where you may not. I'm a new grad, I'm new into the OR. Gosh, if I see something, do I feel comfortable enough to speak up? So if we talk about it and we say that's our expectation that you will, we can kind of like name it.
They're so focused on teaching the Periop 101 class that AORN created. Maybe they can build a module for something specific like that and build it into the Periop 101 program, because people are teaching straight from the program, and if you would add it, it would help.
Yeah, I definitely, I think that would be a good place to start. Another thing though, what we found in the literature is that team dynamics is not sort of a one and done. I wonder sometimes if it was a module would people just kind of click and go, yeah, I got it. But I think it's a great place to start for sure. At least introduce it for sure. But what we'll talk about like later in the literature, what it really says is that we should be sort of having ongoing simulation and role playing, like on an annual or even more frequently than that to keep it keep everyone alert. But I think that's a really good.
Yeah, thank you, Squirrel. Right. Yeah. And the other thing is we're really lucky at our, but we've created this. We're really lucky that I asked the director if I could start creating a surgical services newsletter. So she was like, oh, absolutely, that's great. So it's a quarter, it was monthly, it's too much, a quarterly newsletter. So we introduce the vocabulary and we talk about, there's a column for our culture of safety every month. So, and we post that around, it goes to everybody's direct email. So part of it is, like Imelda said, keeping it on top of everybody's mind, keep on using that same terminology to speak up for safety, normalizing deviance, whatever we're talking about. Just keep it where people start to really understand what some of these concepts are.
So before we get to the next slide, I would just ask you to consider, if you had to look at your cell phone right now and on your lock screen, is there a person on your lock screen? An actual person? And it's okay if you have squirrels or trees or flowers, I get it. But the vast majority, I assume, of you have a person or people. And I imagine that they're not random people, unless you just picked random people from the internet that you think are attractive. That's also acceptable. But if you have if people make it on your lock screen, the odds are really good that they're very, very important to you. And I sometimes think of, this is my next slide here, your picture person could be any of these people. These are all, by the way, random people from the internet, but I have no idea who they are. But my point is, your picture person is a complete stranger to me. And if you were releasing your picture person to me, you would be horrified if you thought that I would sort of skip over on a safety aspect, or if I saw something that I didn't speak up about it, or because I have a beef with my coworker and I don't really like her attitude, I'm not really going to communicate effectively with my coworker because I worked with her yesterday and she's not that great, and it's fine, right? Wouldn't you be horrified? Yeah, you would. And I'll tell you, here's what we tell our new orientees. I think my next slide is here, yeah. Okay, so I love aviation, and Jamie, we talked about this earlier. Aviation happens to be kind of, I know it gets some flack sometimes as from safety, and it does come into the news, and there are some adverse events from time to time or near misses. However, aviation still remains almost one of the gold standards for safety. And it is considered a high reliable organization in the sense that it has very, very high risk. When you think about the number of planes, even in the US alone, that take off and land every single day, and the fact that we don't hear about adverse events as much as we do is actually kind of miraculous. And it means there's a lot of people on their game. And so when I come into, we actually had to take 2 flights to come here. And I've flown a lot. I grew up in Ireland, so I go back and forth quite a bit. But almost universally, when I step on a plane, I always glance to the left. And I typically see 2 people. I'm assuming a captain and a first officer, or pilot and co-pilot. And they're always calm. I've never seen them otherwise. Maybe they weren't calm 5 minutes ago, but when I see them, they are. They are looking at a dashboard of things that I have no idea what's going on, but they're strangers to me and I'm a stranger to them, and I trust them explicitly. And they're only 2 of the vast number of team members that we trust. I realize it's not all about the captain and the first officer. There was a whole safety crew behind the scenes. There were flight attendants that had to do safety briefings and safety checks. And if I thought for a second that, let's say, the co-pilot saw something concerning on a dashboard, and then the captain went, "Oh, stop, I know what I'm doing, don't tell me what to do." If I heard that, I would go, whoa, 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 get it together. Can you all talk professionally? I don't really mind that if you don't love each other and you're not BFFs outside of work, I don't mind, because that's your prerogative. But if you're flying my plane, can you please communicate respectfully to each other and get this plane so we land on the other side safely? And if you want to bicker after we get off the plane, sure, go for it. But while you're flying, you have got to respect me. And I know I'm a stranger to you, as all of these people are, but that's kind of how we should be in healthcare.
So our patients, what we always think when they come into our parking garage and they're looking for their place to park and come in the 2nd floor into the waiting room, it's a nice parking garage, it's a nice campus, it's a nice building, the waiting room is very welcoming, we're all there in our scrubs, everybody looks very professional, and we are. But if you've worked in the operating room, you know some of these things happen. there's that surgeon who, oh gosh,
Nobody wants to work with him.
nobody really wants to work with
He's hard to
him,
deal with.
or there's that
She's hard to deal with.
there's that difficult staff member, or I get hounded about turnover all the time, so we got to make this quick, and so maybe I cut a little corner there. Our patients look at us the way we look at those pilots, like, look at them, they're in their jacket, they've got their wings, we know they're educated, we know they know what they're doing. And I always think we want to hold up to what patients think they're getting. And I think absolutely for the most part, we all do. But we all know that there's some of this that at some point goes on in our workplace.
So for Karrie and I, when we were providing these classes at Baptist Health Louisville, we did a literature review about what is going on with communication in general in the OR. And it really fell into 4 different buckets. So hierarchical gradient is have you heard of that term? And I assume you would know what it means, right? It's kind of that fear, even though we say we're team members, and we are team members, it's not like, and again, to use aviation terms, the plane doesn't get off the ground in our ORs unless there's at least 4 people in place. You have to have a surgeon, anesthesia provider, a circulator, and a scrub person. And so, yeah, we all need each other for sure. But within that team, we all know that there's a little bit of a hierarchical gradient, even though maybe a surgeon, of course, has a different scope of practice than nurses do. And again, they can't work without the nurses. But I do remember, and I'm a fairly confident human being, and at least I think I am. But when I started in the OR, I was, I guess, 30, again, a complete grown-up. But I remember being intimidated by the prominent orthopedic surgeons at the time, who might have been 30 years older than I was. And they would say things, and I was like, well, I'm trying to fit in, and I'm trying to be liked. And I can't say that I saw anything that I should have spoken up about, but I do remember feeling that hierarchical gradient and being intimidated and kind of trying to slot along and not try to upset the apple cart. And, you know, I kind of embarrassed now. I'm going like, I should have been more assertive. Anyway, do you all feel that way? And I think the Generation Zs coming up are better about that. But you all feel a hierarchical gradient where you're like, oh, yeah. And, you know, and then we all have kind of had experience. You don't.
I don't have a filter, so.
Okay. And then we've all had, and to be fair, not to diminish any surgeons, they do have a high stress job. I remember working in neurosurgery. And I remember thinking, oh my gosh, I can't imagine looking through that microscope and dissecting a brain aneurysm, and I really need to keep the room calm. And if the neurosurgeon is being persnickety, I would just go along with it, because it's not a point. There's some times where you kind of just keep your mouth shut for the sake of the patient. But anyway, it is a real thing. Lack of psychological safety can be embedded with hierarchical gradient. But lack of psychological safety really means that I kind of want to say something, but I don't feel it's a safe environment. It doesn't necessarily have to do with surgeons, but let's say we talk about complex dynamics with teams, and maybe I worked with Karrie yesterday, we didn't quite get along, she gave me a little bit of attitude, so I don't want to work with her again, and I'm afraid to say stuff. So that's with lack of psychological safety, or you don't feel assertive in your own skills to speak up.
And I think, you know, I appreciate what you said about you're outspoken, and I think that, you know, a lot of us are. You said you came into the OR at 30 years old, obviously with nursing experience, so you had navigated some difficult situations before. But I always think, for me, the takeaway being an education coordinator and working with unit educators is that you might feel, but how about that new grad? Or maybe that more timid, reserved 30-year-old or whatever. And so, yeah, you don't have a problem. I don't either, but I hear you. But I always think that there's people who don't. And so speaking up and letting them know that, you know, yes, you have to own your own practice. You have to do what is right. But let's just kind of talk about it, and let's make it our conversation, where we all know that this happens, whether it's happening to you, which it's not, but it is happening to you, just that we're aware of it. And that just kind of brings that safety to speak about it.
kind of incivility that can be like lateral kind of bullying situation. There's again a lot of you would think again that when we've come a long way that we're all professional adults, but it is still surprising that incivility is still a thing. But that's, the literature is heavy with incivility.
It's actually in this month's journal.
Oh, okay. Yep. And then organizational culture, that goes without saying too, that when you have leaders in the group, you need to have buy-in from leaders. And one of the things was, I said, when I said that I coordinate the speaking up column, there was a very interesting situation where a nurse called a surgeon out for contaminating the field inadvertently. And the surgeon said, no, I didn't contaminate. And they had sort of a back and forth. It's kind of a long story in the interest of time. But anyway, they had a conflict in the OR going back and forth. And the manager was called in the room, and the manager sort of backed the nurse on it, saying, if my nurse saw that you contaminated something, that's the way it is, as opposed to maybe a manager going, oh no, you're fine, and don't upset the surgeon, and that kind of stuff. So organizational culture is super, super important about how we should, managers really do need to role model keeping the environment safe for psychologically safe, and then supporting safe practices. So getting back to just hierarchical gradient, we just kind of mentioned this here, but there's varying positions. I think social domination, I do remember in the days in the OR experiencing that. Hierarchical gradients are still quite common in professions in which have origins of patriarchy. It's just and maybe we'll get better with this, but it's still a thing. And then there is a little bit of social risk too, as I had mentioned. I remember again as a newer nurse kind of wanting to fit in and wanting to get along, and feeling that if I said something, I would risk that social dynamic. So it's just kind of interesting to point these things out and to talk about them so that they're not so scary. Lack of psychological safety. This is something that came up really in the 1990s and really kind of has proliferated in the literature here lately. And actually there's a scale to measure psychological safety, and Karrie and I are doing a little project here on how we can measure it. But this is again kind of going back to what we talked about. Are we confident to say things in the OR? I think there's some cultural factors involved. I will say as well, being from Ireland, I think we were kind of flying under the radar. I grew up in a large family, don't rock the boat. And I do think that I brought that forward with me too, which again, can be kind of dangerous. And it's something I need to identify myself. So anyway, this is a lot of work on psychological safety. Organizational culture, we touched on this as well. I do feel like leaders have a very heavy responsibility in setting the tone and the organizational, because there's really no point in nurses really trying to do the right thing without being backed by their leaders. So this goes without saying. And then incivility, this is unfortunate. Here in the room, have you all seen this happening in your ORs? Yeah. Yeah, it's actually still incredible. Like, we have people in our OR that will literally say, I cannot work with this person. I will not work. Do not put me in a room with this person. And I think it kind of goes back to, again, and I do realize that we all have different personalities, and we all bring something to the table. But I just think it's so interesting how we can't work on that. And we have some solutions that we can work on that later, but it's interesting. Is there anybody in the room who can really say there isn't incivility, or it doesn't come up at all in your facilities? Yeah.
It's like high school.
It can be. And we're all grown-ups and we're educated. It's incredible. It's incredible.
I saw someone back here that says no incivility. Yeah. Oh, yes, there is incivility. That makes more sense. No, and it happens, and we all know it's not just in healthcare. We hear stories, we have it, hear it from our children, from our friends. It happens in other areas, but we know within the OR, whether you have a background in nursing, working in some other area, something about the OR, and I think it's that team, that dynamic, that hierarchical gradient. I don't know what exactly causes it to be researched, but.
And I think it's these ad hoc teams, like, so, you can be, okay, you, and you go into room 22 and you'll stay there for the entire day, and good luck. And you'd like to think that, and this is kind of coming up on a future slide, but this is what I kind of go back to let's say the aviation team again. Our goal is to get the plane off the ground, fly it safely and land. Whatever issues we have with each other, maybe can be taken back up after work if we want that. But we really do need, there is a picture person, and it could be my picture person that's very important to me, who is a stranger to you, under the drapes. And I think as well, kind of like the question that I put forward earlier, I would be horrified if I thought that my picture person was under the drapes, and there's these two adult professionals that just say, I'm just not communicating. I didn't really quite hear what the specimen was, and I'm pretty certain it was blah, 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 breast biopsy, but I'm not going to deal with her because I dealt with her last week and she's really annoying. And if I heard this as a parent, with my child under the drapes, I'd be horrified, and I know you would be too. So I think it's something we just need to remember in our role and the responsibility that we have for the patients or the passengers that are coming into our ORs. I think we just kind of talked about this, like, why are there negative team dynamics? I think it's almost impossible, the fact that somebody has lived decades of their life and now they come into the OR, and I think all of you are amazing people, so you're all strangers to me, and I'm certain that if I had to sit down with you for an hour, we would find something to talk about. We would all be respectful. But what about then, now we have to work together? Maybe there's parts of my personality you'd find annoying, perhaps. I have political views, I have values and stuff that may differ to you. How would we get along? But that really shouldn't be the point, because what's our common goal is to kind of, again, get through the day. I shouldn't get caught up with, well, somebody has a more aggressive personality, or I'm kind of quieter, or whatever. I mean, it really isn't, there's room in the garden for every flower. And I always say that the only person, I've been around annoying people, but the only person I can control is myself. And so I can say all day long, yeah, I'm not working with her, it's all her fault. She's really the annoying one, it's not me. But maybe, am I playing a role in any of this? Am I playing into the antics of somebody else? Am I too proud to say, okay, well, we can talk about this later, but right now we have a patient coming into the room that's going to have a back fusion, and so this patient deserves our attention. And so I think it seems like a very common sense thing to say, and it's hard to say it. But we're grown-ups and we're professionals, and again, there's an actual picture person, and somebody's picture person that's coming in under the drapes that is probably in one of the most vulnerable periods of their lives, that deserve us to give them the attention they deserve.
So one of the key things that we're going to talk about in the second part is how we took all of these things that we kind of knew and what we're doing to try to change the culture in our hospital, because you can't do it by reading a journal article, and you can't do it just one person, and how we've kind of have developed this, and we have some amazing leaders who have been backing us.
Yeah. Also, we're multidisciplinary. The focus of the surgeon is going to be different than the anesthesia provider, fast-paced, high-risk, high-stress environment. So I think, again, it's you know, that's adding more risk. I remember Karrie asking me, because I work in academia now and I do some education at the hospital, but she asked me if issues in academia. And I'm going, not really, because we're kind of in offices. It's not like I'm stuck in a room, but I do remember those days. And so I do think adding the fast pace, so when somebody's putting pressure on you to work faster, but my colleague isn't working as fast as I think they should. And so now I'm frustrated. And so I think that, again, the OR is ripe for maybe some eye rolling and some other uncivil type things. But communication failure is a third leading cause of perioperative errors. Cognitive factors and lack of competences are up there as well, 1 and 2. So our goal is not necessarily to avoid conflict. Again, we're all human beings, and I was just saying that we all bring something to the table. We all have, what I find might be a strength in somebody else might find it annoying. I think, Jamie, did we talk earlier this morning at breakfast about like our personality types? What you might say, oh, I forget what word you use, but somebody would say, well, is that too aggressive? You know, or we would say something and somebody else would say, no, but I really think that's a strength. And so we all do bring a flair to the table, and it's just about kind of realizing the power that we have and using our strengths as a power and that we can work together. And it can stimulate beneficial change. Again, there may be some conflict, but it doesn't have to be a negative. So this is something that we have done in a skit before, Karrie and I, and it's actually something that I've experienced firsthand, where Karrie is a scrub tech and she's setting up her case. I'm the circulator, and the front desk is calling me to go get a patient. And they're asking me to go not slowly, but quick. Imagine that. Karrie, you just started setting up your case.
Yep, here I go.
And I go,
all right.
Hey, Karrie, they are giving me pressure at the desk. I need to go get the patient. Can we count real quick so we can kind of get that out of the way?
I'm not ready to count. I just opened my pack.
Yeah, I know. But since you're sterile, I really just need to get the patient. So can we, I know.
Hold on, wait, didn't you take a 45-minute lunch? I haven't even had lunch. I've got to get this set.
Yeah,
come on.
I know. They're screaming at the desk though, so let me get the patient.
No, but you do this
Karrie,
all the
I'm not asking you to do something. Just, can we count? It's just, I just need to get the patient.
Fine, we'll
Okay.
count. Are you ready?
Yes.
Okay, let's go.
Stop
We're
the
gonna
attitude.
start
I just need to get the
We're gonna
patient.
start with laps. You ready?
Yeah.
1, 2, 3, 4, 5. You got that?
Was that hard? I just need to get the patient.
I'm
Okay.
a professional too. I've got stuff.
I know, but I'm getting the patient.
Then come back from lunch on time.
Okay.
I swear, she does this all the time. All the time.
Okay, so in the meantime, I'm going to get my patient, and I meet you in the hallway. You ask me nicely, how's my day going? I'm going, it'd be fine, but I'm working with Karrie today. You know how she is. And then you say, oh yeah, don't get me started. And now we're building up.
And you know what, Imelda, she's one of those people. What, is she the only one? She gets a 45-minute break? I mean, she does it all the time. Then she comes in rushed. She puts pressure on me. Hello?
Okay, so you see what we've done. So this is poor unsuspecting person going to be coming into our OR, and it could be any of your picture people. Maybe for a complicated breast biopsy that requires one of those biopsies where they're taking multiple ones, and if you do the thread is at 12 o'clock, and one of these kind of complicated ones. And this, again, unsuspecting woman is coming in. Now, again, you'd like to think that we're professional, we're grown-ups, and we would be kind to our patient. I think that was a fair statement. We would be. And I will do my interview. But I bring my patient in, and let's say it's your picture person I'm bringing in, your mom or your daughter. And I still don't like Karrie very much because of what happened. I'm not crazy about her. And we get along, but we're kind of like going, you know, of sighing. She knows I don't like her. I've already talked to you about her. So, you know, we all know how she is.
And the surgeon came in and said, why are we running late? And I said, well, because Imelda takes a 45-minute lunch. But I mean, but she's on to get the patient now.
Okay, so I would like to think that if we had your picture person in, that the case would still go well, that we would, whatever the complicated breast biopsies are, that I would be able to hear it from the field as a circulator and write them down and do the right thing. but what if you're you still don't really like me, and I'm asking you to clarify something, and I'd hate to think that this would happen, by the way, but we are increasing the risk of something sort of being missed, or I don't want to ask her one more time because I don't want to deal with the attitude.
I could tell her in 1 second what color load we need, but I'm going to let her search in the hold items. I'm not going to tell her that it's the red ones.
Yeah. So also, I'm very convinced that, let's say, what we just acted out here, I came to work today to not make any errors and to treat my patients well because I'm an ethical human being and I'm a grown-up. I am very certain that Karrie also came to work today to be an ethical human being and not to make any errors. But we as in people, have a really weird sense of unprofessionalism when it comes to something like this. And even though we would never want to harm your picture person who's a complete stranger, you can see where our nonsense could potentially harm that person. And I think we just need to talk about this and just weed it out. Because when you say, who was in the wrong there? I was like, we actually do this little thing and people go, well, she was in the wrong because she really should have just realized that you were being pressured from the desk. And so what was the big deal just counting? And then other people say that I was in the wrong because I kind of like rolled my eyes and go, was it that hard? And I was being uncivil. But who says that I was in the wrong? You're the only one. Do all the others think Karrie was? Oh, okay. Both of us. Both. Yeah. Yeah. How about anesthesia, who weren't there at all? Yeah. Yeah. We'll blame them. Yeah. So what could have happened there, if I'm behind it being my professional self, and let's just say Karrie is a little contrary sometimes, let's say she is, I can control me. So I really could have said, I could circle back and say, Karrie, I might have been short with you, and I'm sorry, honestly, they're putting so much pressure at the desk, and I just really need to get that patient. Like that would have just eased it off. If I would just let my ego go a little bit, that would be nice. Or
if I would have said, you know what, I know that we were short on scrub text today. I didn't really get a morning break. I know I'm short. Hey, if you could just give me 1 minute to get through exactly what I'm doing, I'll stop and count and I'll finish while you go get the patient.
Yeah.
We're going to be at counting in about 5 minutes and I'll be there as soon as we finish.
Yeah. We could do that too. Yeah, there's other ways. And I think the key is we need to be able to communicate respectfully. So like you rolled your eyes at me, I was kind of annoyed. And this is kind of what we hear, this is actually came from an article, but so we kind of just put in random names. But really, when I made condescending comments to somebody else then feels threatened and feels personally attacked. And then she's saying, well, I'm not letting that happen. So I need to attack back because again, we have egos and we're, I know how we are. And then the outcome is our personal relationship between we're damaged and both parties are distracted from our work. And we can't, and again, it gets back to, if you thought for a second, your flight safety team, before you got on the plane, were acting like that, you'd be going, guys, stop it. Get it together, do your safety checks, speak professionally with each other. I don't really care that somebody is aggressive or mean or something. We've got to be able to communicate because the stakes are very, very high.
And I know Imelda has in other projects shared some of these things that we find in the OR with other professionals. I know that our leaders, it's like we all know that this isn't like rampant in every single unit, but there is unless that one person that said I would not even have my dog, whatever. We had that one comment from a random person, but to know that these kind of things do happen at some level, at some time with some people, I think that's where because we all have those people that we know in our unit that you don't work with her because you all just don't get along, and you've set that straight. And so just to talk about it is what I think really the value is, because I'm sure if you're here today, you're engaged, you're, you know, professional, you go in every day to do your very best, and you're maybe thinking this wouldn't, I would never, but you maybe have seen it happening.
This is an interesting thing we found in an article too about pivotal first steps, and then there's a whole literature. We could talk all day about this stuff, but I thought this was interesting about kind of applying emotional intelligence. We can only, again, control ourselves. And there is a thing when we perceive a threat to our ego or our domain. Let's just say Karrie, again, is a really good scrub tech, and I was kind of threatening her domain in that little skit there. Our amygdala actually gets flooded with stress hormones, and it actually impairs our judgment sometimes. And it's kind of why people can, and I quote, fly off the handle sometimes when they normally wouldn't, or they'll say things or they'll raise their voice when that maybe not normally what they should have done. And I think we should be aware of that, about when, again, our ego or our domains get threatened or we perceive that. It actually, there's a physiological response in our brain. And I think just kind of being mindful of that, maybe there's a time when we just need to step back and let our brain sort of recalibrate. And again, we kind of forgot to point out, I, you know, went down the hallway and I talk about Karrie to my colleague. Well, now I'm actually now adding fuel to the fire, because maybe you need to work with her tomorrow and you're already don't like her. And now we're friends and we hang out in the break room. And I think we can get so nonsensical because we're grown-ups and we're professionals. And it's not like what we do is, the stakes are very high. And so again, just kind of reminding ourselves of where we are. One of the things here, and this is on the future slide too, the fact that, again, getting back to our little role playing, Karrie and I both came into work today to have a decent enough day. We don't really want, I don't know of a single soul that says, well, I'm going to fight with my coworkers today, or I'm going to set the stage for some adverse events. I don't think anybody in their right mind would have that goal for the day. So the fact that we have a common goal to get through the case safely and to keep our patients safe.
Land the plane.
And land the plane,
yeah.
That should be enough for us. And to maybe step back from this, again, egotistical situations that we're getting involved in, and we want to one-up somebody else. So some solutions. This is kind of what Karrie was mentioning earlier about some things that we've kind of put in place at Baptist Health Louisville. We found in the literature that solutions to this is multi-method approaches. So you had mentioned again about putting it as a module. I think that's a really, really good first step. But just to follow up again, it really should be simulation, didactic, video, role playing, and having these things as part of our ongoing education, in addition to all the other things that we do. And you all do e-modules, I assume, with where you're all trying to get through 300 modules before the end of the year. And so we get so desensitized to that. And so I hate to say, well, let's just add one more module on communication, because I don't feel like people would take it seriously. It's a great first step. But I would definitely argue that if your leadership allows and backs it up, not only maybe having a module, but also maybe some real-time role-playing and serious, because I honestly think that we do need to be able to communicate better in the OR.
Yo, menopause is a bad thing.
So some solutions for hierarchical gradients. Some facilities are very good about this, but I think we should also establish a lateral relationship and not see somebody as higher or lower than us, regardless of, now somebody can be more experienced, but like not having a new, I mean, I've seen this too as a newer nurse, you know, a scrub tech who might have been, again, very experienced, but really kind of bullying me as a younger person. I mean, we need to like root that out and talk about it. That should not be the norm, and that we have lateral relationships, and we lean heavily on each other, because we can't be good at everything. And then kind of relying on each other's strengths. So does anyone use the cuss? It's actually came from the AHRQ. Okay, do you use it in the OR? Yeah, I think that's amazing.
Do you use it as part of your timeout?
We use it throughout the day. If we don't use it only in our OR, we use it system-wide, and we have multiple avenues. We do the readbacks and things to that aspect also. So that's bars.
Yeah.
Okay.
I think it's great, and I don't think we use it enough in our OR.
Well, interesting enough, I know, Leah, you mentioned to me earlier, like you wanted to do some stuff with your nurse scientists, and I told you what a great mentor Imelda's been for me. So Imelda's at the hospital 1 day a week. We have a few ongoing projects that we're working on, but this is a project that I want to start with maybe a couple of staff members and kind of, you know, get those tentacles start going out. So the PICO question would be something like, how does implementing, so we find an assessment tool, like how does implementing the CUS tool in maybe just the OR during timeout, like verbalizing that this is a safe space, you know, where everybody can speak up for safety. How does that affect your, the nurses, the scrub tech's sense of psychological safety? So it's really in the infancy. We all know fourth quarter and ORs are crazy. We also have a transition of our OR anesthesia providers. So it's something I want to start working on with Imelda being kind of my mentor. So I'm really lucky for that because my person is so OR, but she's busy, but she can help kind of guide me. And then we have that nurse scientist on staff who can actually help me kind of craft my PICO statement and kind of, you know, and then I'm going to be, another thing we have is an OR safety committee. So which I facilitate. I'm not the chair, but I facilitate. And so let's start handpicking some of those people to really like get engaged. And this has been baby steps. Over how many, 3 years have we been working on this?
But I think, again, as Karrie was saying, maybe when you're doing your timeout, and to also say, not that we need one more thing, to be honest, but maybe saying, and cost will be used as needed. And then you're kind of setting the precedence that if somebody needs to speak out about anything, then that is going to be acceptable. But I don't think there's any literature on using it specifically in the OR. I mean, it's a tool that is around like hospital-wide. But I would be interested in kind of.
Wow, maybe I'll have a poster at this, at a conference in a year or two.
Yeah, and I think team huddles, I think that's actually a really good approach as well, because that sort of normalizes and gets relationships that are lateral as opposed to, well, I wouldn't be able to say that because they're a neurosurgeon, that kind of stuff.
In our ORs, we do a stop the line that we both educate on, and CUS is part of that stop the line language. So everybody across the board, from surgeons to anesthesia to nursing and our technologists, all know if somebody says the word concerns, everything stops.
Oh, good. And it's respected, obviously. People like, yeah. I think that's great. I do.
I do too. Yeah, for sure, because we do. We're on. Baptist has. We want to be a high-risk organization, and we implement all those. We have the skills of and we have safety coaches, and we have people out there doing audits. But I do, that's like a whole different section. But my role as education coordinator is kind of like these overarching things. I'm not teaching people, you know, how to use the count sheet. And so it's always implementation, getting that buy-in. One more thing, whether it's a change in Epic or it's a change in a supply, and just getting that buy-in and then auditing to make sure it's happening. Because as a person that is engaged in some of those safety meetings, I hear it from us all sitting in my office on the Teams meeting or going to the conference room. But those aren't the people that are in the room, because they couldn't get out of the room to go to the meeting. And so our issue is, okay, so that's really nice where it's my position was just created about 3 years ago, where I wear scrubs every day and I just float in and out. I might be in a meeting with everyone in suits, and then I might be in a room, like just helping a new orientee or just, you know, supporting somebody or teaching a class about, you know, psychological safety. So, and I really realize that a lot of areas may not have a role like a position like I do.
Just improving psychological safety. I think, again, having repetitive, multifaceted intervention. So like not just sort of one PowerPoint and then we're finished, just keeping it in the limelight, talking about what it really means. And then setting the precedent so that culturally, it's safe for people to say stuff and we're not rolling our eyes at somebody who says, you contaminated that field. Fortifying organizational culture, I think this goes without saying, but nursing leadership's substantial role to play. I do feel like a lot of facilities now are having leadership teams and leadership classes, and I do think that hopefully we're getting better at that. I think one thing is, this was at an AORN conference a few years ago. I spoke about another thing called normalization of deviance, and a young lady from Texas approached me afterwards saying she had a real problem with safety issues and cultural issues at her facility. And I said, have you brought it up with your educator and manager about this, about some ideas? And her first response is, well, they're part of the problem. And so you can kind of see, ooh, that's really hard to deal with when that's the case. And we could talk all day about that, but that's really unfortunate. My heart broke. And she was actually, I feel like she was a very young nurse, really trying to do the right thing, and she was kind of in a stuck place. So I felt bad about the organizational culture at her facility. Conflict management strategies, just to kind of circle back to emphasis on commonalities rather than differences. Maybe explaining to our staff that we don't need to create a small little conflict in a room and then make it grow legs and monster-like to the point where we're ostracizing another human in the break room and socially. Conflict management strategies, some role playing. And again, just seeing that from a common ground standpoint, we're all here today to get that plane off the ground and to land on the other side safely. And I just think that's a great thing to always remember. And that, again, there are people in our midst that are under anesthesia, cannot speak or breathe for themselves, and that they trust us explicitly in the same way that we wouldn't think twice about our flight team not treating us well. And so understanding that. Some considerations. We're not here to paint, and I know you're all aware too, we're not here to paint this glossy picture that will solve the world problems overnight, particularly in the OR. But just some considerations here. Ad hoc teams, kind of as I mentioned, we're picking these random people every day, putting them in a room with high stress, and sort of understanding that that is really hard on any humans, understanding that. Also, this is in the literature, psychological safety can sometimes be overcorrected, where everyone's talking all the time and bringing up things. And I think there's a point where we maybe can overcorrect a situation. Maybe we need to consider some guidelines on what is accepted and what isn't. Interestingly, sometimes, and this would be some facilities, where the perception that goes on in the room and the direct care can be different than the ones in the offices. And so there's not enough education and attention put on that. I do know this has been in the literature. When you measure culture of safety usually has higher scores in those who are not in direct care. So sometimes there's a perception that things are fine in the room, you just need to hurry up a little bit and do that. And so we just kind of need to pay attention to that, about what's reality and what's perception. And then I think it would be very hard for logistics. Karrie and I have been able to bring nurses and techs out of the rooms for some training, but we haven't even touched on what about bringing surgeons into training or anesthesia providers? That's a logistical nightmare. And so there's a logistical issues. And they were also, again, these are businesses we're running, and there's a cost of team training as well. You're having people like clock in for education, but they're not productive in the work standpoint. So these are all some considerations that probably need to be ironed out and worked through.
Imelda, we only have about 5 minutes left. Yep. Is the next slide talking a little bit about what we what we did, because I just want to say, so how this all started for us was we had a friendship. I knew her from AOR and our chapter meetings, but and she'd work and people talked about Imelda. But after COVID, we had, like a lot of us, we had real staffing challenges, and everything was taken, orientation, onboarding was all taken virtual, Teams, and whatever. And I didn't like it. I thought, gosh, I want to see these people. I want to make sure they feel welcomed. I want to, this is after COVID. So we were lucky enough at that point to have our director. We had an idea of the whole facility was still doing virtual orientation, like that HR orientation. And we wanted to bring our people in, surgical services, all surgical services units. We wanted to bring them in, so at least we could watch that together, that virtual orientation. And then what we were trying to do is create, wanting people to feel like, I know who you are, I know who your name, you're very welcome, not from your couch. So from that, we also said, we want some classes that aren't all technical, that can actually develop this other part that we don't talk about, which your communication skills. There is conflict. How do you resolve that? Specific to the OR and surgical services. Pre-op's running late. Oh, pre-op, like all of that. So we wanted to, so we started with just our new hires. We started with just new hires. We met with them once a week, Wednesdays at 2 to 3 o'clock in the afternoon for 6 weeks. And every week we had like a slide deck, and we might be going over, it might be normalization of deviance, or it may be conflict management. And we went over these things with some role playing, some team games to kind of show how teams work. And we collected data, and we're still collecting data. So we had some views. We did a survey before, and then we did surveys after. So anyway, with that, then we were able to move on. So we have all of our new hires that we really feel great about it. It's a safe space. Everybody's opening up, talking. This is great. At the end of the 6 weeks, it's like we dumped our fishbowl into the ocean. And now we're like, go, I hope the shark doesn't get you. Just remember what you learned. So we knew right then we have to make sure everybody knows this. So then we started with preceptors. So of course we did this, and we're giving CEUs and credit. So then we started with preceptors, and we again said, well, let's try to collect some data. So that's what we're doing now, preceptors. And our next step would be then we need to make something where it hits everybody else. We have the new people and preceptors, scrub techs and RNs, preceptors. Now we need to, those people that aren't a preceptor but have been there for 5 years, we need to start implementing that. So that's kind of how we started it. It really came from just a need and a want to connect to people after this high stress pandemic, bringing people that had never worked into the OR. And that's what it was. It was new to the OR hires. So it definitely didn't get everybody, but that's how we started and how we're trying to spread our tentacles.
So this is it for us. It's 9:29, soon to be 9:30. So is that it? We have a new.
If we have some time.
Okay.
I'm gonna take questions from the audience.
Squirrel.
One of the ways that we help the doctors with the communication problems is if a doctor got reported for issues more than once, he was sent to they call it manners class.
Oh, I like it.
And they're fine.
Fine.
Monetary fine.
Oh, wow.
And if you have to go to manners, every time you go to manners class, your fine increases.
Oh,
Like a parking violation.
And it's not a low fine, it's not like $50.
now what?
The person in charge of the doctors, like as far as who was in charge of the surgical doctors, my brain's not on yet, sorry.
Yeah, it's fine. But it's only for doctors. Is there anything in place for like cranky nurses?
We're having management issues, so it's not being handled as appropriately as it should be.
Yeah.
We've given a lot of suggestions, it's just not panning out yet.
Yeah.
But they're clearly waiting for doctors, and apparently
That's good.
manners class and the fines have helped.
Yeah.
Has anybody, I'm sure people are collecting data on that to see what's going down, how it's affecting it.
LCMC is a system that's taken over the hospital I'm at, and they're based in two-lane research and stuff, so they're actually doing stuff with that.
I can't imagine how that kickoff went, how that email read.
Yeah, JD.
So we're definitely a tremendous amount of research. And one thing that I would love to see in your data is anything that's tied to the well-being of staff.
Yeah.
But two, retention rates.
Uh-huh.
And a third aspect is to, on their exit surveys, is to have a component to see if there's anything that's why they're leaving.
Yeah.
Is there something that's comparative to the communications?
So I love that you say that. I can address the exit surveys. I've been talking to HR because I wanted to know, I think our retention rate's gotten so much better. And I think we're in a really good spot right now for both nurses and scrub techs. But the problem that our facility had, and it was a Baptist problem, was the timing and how they sent that exit. The exit survey was an email survey that was sent to their work email. And I'm like, this does not make sense. Nobody's going to fill it out. There's no value for them to fill it out. So how you have ideas about that?
Well, we have two forms of communication. One is your work email, and you choose, which about 87% of our staff, we have 15,000 employees. 85, 87% of our staff actually gets a secondary home email address along with a phone number, so you can actually text them or send an email to that personal email. We still only get that less than 14%
Return, but so.
That's still in research, that's considered a high number.
Yeah.
Right. Right. Yeah, because I would think a lot of people would like that opportunity to say, well, I'll tell you why I left.
Yeah, I think you would too.
Yeah.
Some are afraid.
Yeah, I think you had, go ahead.
Some are afraid to share.
For sure. Retribution or.
Yeah. Did you have something?
Absolutely wonderful presentation.
Oh, thanks.
So, what I would say is one of our locations has started a very strong physician onboarding before physicians
Yes.
they sit down with their team,
Yes.
staff, resource nurses or surgical technologists, and explain what is expected and what happens when that's not met.
Yeah,
So,
it's an excellent idea.
has really, I think, reduced a lot of frustration on the surgeon side, and it's trickled down. They understand what the resources
That's gold.
are,
Yeah.
they understand what their roles and responsibilities are, who to ask when they have a problem, which I think has taken the heat off on some of those situations because they feel like they understand how the place works better.
Right. And we talk about our staff, you don't learn this in nursing school or in scrub tech school. They didn't learn it in medical school. So, gosh, that's a dream that we can
It's really good.
take our show on the road that way. But I love that that's happening pretty well. Yeah.
Just a statement, one of the facilities that I worked in did high reliability training, but the classes were combined. It wasn't just nursing staff or just EVS staff. The surgeons were included.
Right.
So it really sent the message for hierarchy.
And then so they go to that initial training, and then is there annual, quarterly? How is it not one of those things that just, oh yeah, we're doing this again? Daily huddles, we do too. Sounds very familiar. I mean, it sounds exactly what we're doing at Baptist as well. So as you can see that I'm saying that we sound a lot like what you and JD are saying. That's, I think, why we were lucky. Our leadership, when we came up with some of our project ideas, they were like, absolutely. Yeah, we were lucky.
So thank you all so much
Yep.
for your time.
Thank you.
Yeah, appreciate it.